Hi, my name is Amanda Ingley. I'm a nurse practitioner student at Maryville University, and I'm going to be demonstrating my head-to-toe assessment today. I have my volunteer patient. She's a 59-year-old female. Before we entered the exam room today, we obtained her height and weight and had her empty her bladder. We also tested her distant vision using the Snellen chart outside the room. We had her occlude her right eye and from a distance of 20 feet, read the furthest line possible. And again, we tested her right eye as well by having her occlude the left eye at 20 feet and having her read the lowest line possible. And her distance was 20/20 with that. Now that we are in the exam room today, typically we would have the patient undress and gown. This facility does not have a gown, so we're improvising and just trying to respect the patient's privacy throughout this video. We will wash our hands, introduce ourselves to the patient, and I'll go ahead and obtain a set of vitals. On 15/75. Thank you. And pulse of about 65. So we are wanting to note just the general appearance of the patient. She appears overall healthy, and throughout the assessment we're going to be looking at her skin and assessing that as well. Starting with the head and the face, we want to look at general symmetry and just inspect for any bulges, any abnormalities, lesions, moles, scarring, bruising, anything of that nature, which all those appear to be within normal limits. We can also go ahead and test for the transgeminal and the facial nerve. I'll do that by having the patient go ahead and just clench your teeth, and a test for the tone for the trigeminal nerve, and that appears normal. I'll also go ahead and test for the sensation. I'll have you close your eyes, and I'll have you tell me if what you're feeling is sharp or soft. Soft, sharp, sharp, soft. Sharp, soft, sharp, soft. Okay, very good. So again, we test the chin, the cheek, and the forehead for the trigeminal nerve. And for the facial nerve, I'll go ahead and have you smile and frown for me, and puff out your cheeks and act like you're whistling, and clench your eyes closed and don't let me open them. Okay, all right, and all those appear good. Next, we can go ahead and palpate. I'm going to palpate the skull, noting any abnormalities. We can palpate the hair, note that that's evenly distributed, thick. There's no thinning noted. We can palpate the facial bones and the sinuses, noting any tenderness. Is there any tenderness that you're feeling? No? Okay. If there were, we can use transillumination to see if there's any fluid behind the sinuses. Let's see. Next, we can go ahead and palpate the temporal mandibular joint. I'll go ahead and have you open and close your mouth. And we're going to note for any pops or clicks, which it appears to be normal. So now we want to focus on the eyes. We already noted it seemed very symmetrical. The eyebrows, eyelashes, hair is evenly distributed. We can go ahead and look at the conjunctiva. I'm going to go ahead and have you look up while I pull down a little bit. You look translucent and good. Okay. And then I'll go ahead and palpate the lacrimal apparatus. We want to check for any fullness. And there appears to be none. At this point, we can check the pupillary reflexes. I'll go ahead and just have you look at my nose. And we want to check that the pupils are equal, round, and reactive to light, which they are. Next, we can check the peripheral and extraocular eye movements. So I'm going to go ahead and stand in front of you. Can you see both of my hands?
Mm-hmm.
Okay, I'm going to go ahead and move one of them. Just tell me if you see which one is moving.
Okay, you're right, left, right, left.
Okay, all right. And go ahead and follow my finger.
Okay.
Okay, so using the H pattern, we determined the 6 cardinal fields of gaze. We can also take this time, if any strabismus or anything was suspected, to do the cover-uncover test. And I'll just ask that you pick a point in front of you, and I'll cover up one of your eyes.
Okay.
We want to look for any movement in the eye that's uncovered and the eye that we uncover as it fixes on the object. And we'll test that as the other one as well. Go ahead and fix to a point. We'll cover up your eye. Okay. And the cover-uncover test is normal. Next is the Rosenbaum chart. This test for near vision. This is held at 14 inches away. And go ahead and read the smallest line that you can. And can you cover up one eye for me, please?
Okay. 2843.
Okay, and go ahead with the other eye.
2843.
Okay, all right. So there is a little bit of vision loss. You do wear readers, is that correct?
Yes.
Okay, all right. So you could also have the patient put on the readers and perform this as well and see if that helps correct their vision completely. Testing the vision in the eyes, we have looked at the optic, ocular motor, the trochlear, and the abducens cranial nerves. Next, we're going to look at the ears. Looking at the head and face, we've kind of looked at the symmetry and the alignment. I'm going to move your hair back here. And they appear symmetrical, and the alignment is good. We can go ahead and palpate the ears for any lesions, and none is noted. We can then use our otoscope to look inside the ear. Get a closer look at the ear canal. Minimal cerumen is noted. Visual landmarks are, all landmarks are visualized, and the tympanic membrane is pearly gray. Looks good. We'll do the other ear here. Pull back a little. And that one looks good as well. Next, we'll go ahead and do some hearing tests. I'll go ahead and have you occlude your right ear. I'm going to whisper something in your left, and just go ahead and repeat what I hear, or what you hear. Apple.
Apple.
Okay.
Baseball.
Okay. Next, we're going to do the Weber test. I'm going to strike this tuning fork and place it on the midline of your head. You just tell me if you hear it in both ears or one versus the other.
Both.
Okay. All right. We're now going to do the Rhine test. The Rhine test, I'm going to hit the tuning fork, place it behind your ear on the bone. When you no longer hear that, let me know or raise your hand, and I'll move it to the side of your ear. When you no longer hear it at the side of your ear, let me know or raise your hand, and that will determine the end of the test, okay?
I don't hear it. I don't hear it.
Okay. So air conduction was about 20 seconds where bone conduction was 10. That would be a normal finding. Air conduction is about 2 times longer than bone conduction. So that appears normal. Next, we're gonna look at the nose. Check that the septum is midline. We also just want to look at the color, note any lesions or anything. We want to note any discharge or flaring of the nostrils. We can use our otoscope to take a visual. Just going to look up your nose here. And the inferior and middle turbinates are visualized, and the mucosa is pink and moist. I'm now going to test the first cranial nerve, the olfactory. Typically in a practice setting, they may have tubules of common smells. I'm kind of improvise with some findings I found in the office here today. So I'll just have you close your eyes and occlude your right nostril. And tell me what you smell.
Alcohol.
Okay. And go ahead and occlude your left. And tell me what you smell.
Coffee.
Okay. All right. So the smell is intact and the nose does appear patent. Next, we can move to the mouth and the oropharynx. The lips first, you want to visualize any lesions, any edema, the color of the lips. You want to look at the teeth and the buccal mucosa, the gums, the hard and soft palate. I'll go ahead and do that now. If you can open your mouth for me. You can use a tongue blade to help you see a little bit better. Okay, and I'm going to look a little bit further back, so I'm going to have you stick out your tongue. Say ah.
Ah.
Okay, and you want to note the tonsillar pillars, the tonsils. You want to be sure that the uvula is midline, that it rises and when she says ah, which it does. And at this point, you could also test for the gag reflex. I'm not going to do that, subject my patient to that today, but at this point in the exam, it would be a good time to do that. Testing the gag reflex would test the glossopharyngeal and the vagus nerve. Finishing up the mouth, I'm going to have you stick out your tongue and move it from side to side slowly, okay? And touch the tip of your, okay? And try to touch your chin with it. Okay, all right. So tongue appears good. When she lifted it up, I could visualize the underside of the tongue, which is important if any oral cancers or anything. Again, you want to check for lesions there as well. And that tested the hypoglossal cranial nerve 12. So moving on, we can examine the neck. First, we just want to inspect it. Look at the symmetry, the tone, look for any masses, any unusual shortness, webbing, anything of that nature. Hers appears pretty good. Also look for any jugular vein distension, which none is visualized. We could also have her do some range of motion exercises. So I'm just going to have you look to your left and look to your right. Okay, can you put your head down? And now tilt it all the way back. Okay, I'm going to have you do the same thing against resistance. So go ahead and look to your left. Okay, go ahead and look to your right. And go ahead and look down. And go ahead and tilt your head back. Okay, so against distance was good. I'm also going to have you shrug your shoulders. Okay, and shrug them again. Okay. So those are some good exercises as well. Testing the range of motion of the neck because it tests the cranial nerve 11 as well as musculoskeletal cervical spine. This patient does have some mild dystonia and does have some difficulty to the right side, so that can be noted in the exam at this point as well. Also with the neck, we can check for carotids. We want to do them at separate times. Okay, and auscultate the carotids, listen for any bruits. Go ahead and take a deep breath and hold it. Okay. Take a deep breath and hold it. Okay, very good. You can also assess the trachea, make sure that's midline. Go ahead and swallow. Look for any tracheal tug, which there's none felt. You can also assess the thyroid. Make sure that's palpable, no lesions are felt. Go ahead and swallow for me. Okay, and that's normal as well. The thyroid can also be auscultated, listening for any bruits, which could occur in a hypermetabolic state. And none are heard. Ending the neck exam, we can check for any lymph nodes. We can check starting at the pre and post auricle to the occipital and the temporal to the submental, submandibular, down the cervical chains, the deep and superficial, supraclavicular. Okay, all right, and those all appear normal. Nothing's enlarged or firm. Moving on to the upper extremities. At this point, we can go ahead and check her range of motion in the shoulders. You go ahead and lift your arms up for me and put them behind your back. Go ahead and swing them across the front. Okay, and go ahead and just let me move your shoulder, listening for any pops or clicks, which there is none. Again, you want to test that bilaterally on each side, or just in one shoulder, if depending the patient's complaint. Her shoulder appear normal. Also with the arms, you want to look for any discoloration, any lesions, moles, any abnormalities. Her hair distribution is even. The hands, we want to look for any clubbing or swelling of the joints or the fingers. Check for capillary refill. Hers is less than 3 seconds. Fingernail integrity looks good. Can you go ahead and put your fingertips together for me, the fingertips. And no clubbing is noted. We can now check for the brachial pulse and the radial pulse. And those appear strong, regular. So now we can move on to the back. I'm actually going to have you turn away from the camera here, and we'll expose your back a little bit. Looking at the posterior back, we want to just determine that the spine is straight, the thoracic configuration is normal. Look at the skin again for any discolorations, any abnormalities, which her spine is straight, nothing abnormal noted here. We can also test the costovertebral angle. So I'll just percuss. Please tell me if you feel any pain. Any pain or tenderness?
No.
Okay. All right. While we're here, we can check for lung expansion. So about the 10th vertebra down along the spinal process, I'll place my thumb and go ahead and take some deep breaths. Deep breath. Okay. And that appears normal. I can now check for tactile fremitus. So I'm just going to move my hands along your back while you repeat the words 99.
99, 99, 99, 99, 99, 99.
Okay. And hers appears normal. If there was an increase in fremitus, it could possibly indicate fluid on the lung or a mass that might indicate further investigation is needed. We can now percuss the lungs. With resonance noted. and that sounds good. We can also test for diaphragmatic excursion. I'm going to grab some tape to mark that, as well as a ruler. And I'm going to have you take a deep breath and hold it. Okay. And again. Diaphragmatic excursion should be about 3 to 5 centimeters, and hers is about 3.5 to 4. Okay. At this point, we can now auscultate the back of the lungs. We want to use a side-to-side comparison. And with the mouth open, take a nice deep breath for me. And out. Deep breath. And out. Deep breath. And out. Deep breath. And out. Okay. All right. So moving back anteriorly, we can assess anterior and lateral parts of the lungs. It can help if you have the patient hold their arms above their head. And again, using a side-to-side comparison, I'm going to have you just take a deep breath. In and out. In and out. Okay. You can spend more time listening for the time restraints on this video. We're moving a little bit faster today. Next, we're going to focus more on the heart. It should be noted that the patient's respirations are quiet, even, unlabored, no distress with breathing. So that's something to note as well. With the heart and lungs, again, when you auscultate and when you're listening and when you're inspecting, you would want to do it with a bare chest for the patient's privacy. We're not doing that today. But you'd want to look for any heaving pulsations, and you want to check for any thrills. So you can palpate. You can palpate the left border here and check for any mitral pulses, heaving, or thrills, which none is noted. You can also do the aortic and check for any pulses, heaving, and thrills, which none are noted as well. You can check the apical pulse, which I might have you lay back a little bit here. Okay. Feel for the apical pulse, usually the 5th intercostal space along the midclavicular line. Okay. And at this point, you can also palpate the infraclavicular and the oxyculary nodes as well, noting for any enlargements or firmness. And those appear to be within normal limits. We can now go ahead to auscultate the heart sounds. We want to do this in a systematic fashion as well. We can start with the aortic at the right 2nd intercostal space, midclavicular line, and then move to the pulmonic on the 2nd intercostal space on the left, right by the left sternal border, moving down to the 3rd intercostal space for the tricuspid, the 4th intercostal space for the Erb's point, and again going back to the mitral valve along the 5th intercostal space along the midclavicular line. Typically, you would want to auscultate each point for a series of a few cardiac cycles, listening for any murmurs or gallops. And no murmurs or gallops are heard. If you were suspecting something or wanted a closer look, you could have the patient change positions. You might have them lean forward, lay to their left side, lean back, anything to kind of segregate some of those heart sounds. I'm now going to have you lay back all the way, but forward first. And we will go on. Onto the abdomen. With the abdomen, you want to look for any abnormalities, bulges, any scarring, any pulsations, which hers is within normal limits. No pulsations or bulges are noted. We can now auscultate the abdomen, which we do first. We want to listen in all 4 quadrants. If bowel sounds are hypoactive, you can listen anywhere from 3 to 5 minutes. Again, for the time restraints of this video, we're kind of moving through this a little quicker today. Also, with auscultation on the abdomen, we can auscultate the aorta, the renal, the femoral, and the iliac arteries with the bellows stethoscope. I will do that at this point as well. Tomorrow. Okay. We can now go on to percussion. Dullness is a common finding over the abdomen, as well as tympany. Dullness is heard over solid organs or masses, where tympany is heard over the air-filled spaces. We can also percuss the liver span as well as the spleen. So again, I'm going to grab my tape over here. We'll go ahead and percuss the liver. Starting from the mid-axillary line right below the lungs, I'm going to start percussing. And from the umbilical line, I'll work my way up. Okay. Again, listening for that to change to the dullness. Go ahead and measure. Typically, it's anywhere from 6 to 12, and hers is right at about 6. Now I'm going to have you roll to your right, your left side, sorry. And no, that's right, yeah. Sorry. And we'll percuss the spleen. You're gonna do the mid-axillary line, typically at the 9th to 11th intercostal space. Again, we're gonna look for any dullness here. go ahead and take a deep breath. Okay. All right. Go ahead and lay back on your back, and we'll go ahead and now do palpation. For the stomach, we start with soft palpation and work our way towards deep palpation, starting with the right upper quadrant and working in a clockwise manner. It's important to always look at the patient's face to see if there's any discomfort or tenderness that's noted. We can also palpate specific organs as well. So we can palpate the liver. I'm going to slide my left hand underneath you here and go ahead and take a deep breath and out. Okay. I can palpate the liver. While I'm on this side, I can go ahead and palpate the right kidney. So go ahead and take a deep breath and out. Okay. Kind of cup it between both hands there. So go ahead and move to the other side. The left kidney here. Go ahead and take a deep breath and out. Okay. And we can go ahead and palpate the spleen. Go ahead and take a deep breath and out. The spleen is a little bit harder to palpate, and sometimes it's not even palpable unless it is enlarged. We can also check for the abdominal reflexes here. You just want to look that the abdomen kind of contracts, which it is. If you suspect a patient to have appendicitis or something going on in the abdomen, there are a few muscle tests you can do. You can do the ileosis test, which I'll have the patient raise the right leg straight, and I'll push down on it. Let me know if there's any pain. No pain? Okay. If they were having pain, it would be a positive sign that could indicate appendicitis. There's also the obturator test, which I'll go ahead and have you flex your knee. And I'm going to go ahead and just let me rotate it laterally and medially. Any pain?
No.
No? Okay. If this were positive and they had pain, it may suggest a ruptured appendix or even a pelvic inflammation or mass of some kind. So go ahead and have you sit up there. All right. So moving on to the legs, again, we want to look for any symmetry. Note the color is equal. We want to note the hair distribution on the legs. Hers are clean and shaven. Note any scarring, lesions, or abnormalities, which there don't appear to be any. Look at the toenails and their skin integrity. I'm going to pass over to the other side here. And again, we want to check for the warmth, any edema, and no edema is noted. We can feel for the popliteal pulse. Okay. The posterior tibialis and the dorsalis pedis. Okay, and those appear to be fine as well. We can test the reflexes. Again, you want to do this bilaterally. For the sake of time, we will just demonstrate one side. Brachial reflex, I'll have you just hold your thumb upright. Relax for me. Okay, you want to see that thumb move and feel it in the arm as well. We'll go ahead and check the reflex of the knee. Okay. And the Achilles tendon. Just go ahead and relax your leg. Let me flex it. Just relax it for me. Relax. Okay. And reflexes are good. Muscle strength was noted watching the patient walk in today. Her gait was steady, fluid motion, purposeful. No atrophy is really noted in her muscles. We can test muscles, the major muscle groups. Just go ahead and hold your arms out and go ahead and try to bear down. Okay, now pull up. And try to push your arms out and push your arms in. Okay, and her muscle tone appears to be strong. Go ahead and do the same thing on your legs. Push out. Okay, pull in. Push on my hands. Push against my hands. Okay. So her muscle tone appears to be strong and within normal limits. We already assessed her cervical spine during the head and neck portion, but at this time we can assess for the lumbar spine. So I will have you stand up and go ahead, if you could bend over. Okay, and go ahead and bend all the way back. Okay, and can you bend side to side? Okay, and are you able to twist for me?
Yes.
Okay, perfect. Any pain with that?
No.
No. Okay, go ahead and sit back. All right. So that completes our head to toe examination today. You can see that as we went through the body systems, we also incorporated the cranial nerves as they were, as they fit. The overall assessment was pretty much negative, some slight cervical dystonia, some slight visual loss that may just be determined to age. But otherwise, I'd like to thank the patient for volunteering and you for watching. Thank you.